Welcome to today's webinar. My name is Russ Rowan. I'm the Director of Marketing at Osteogenics. Before we get started, let me address how we'll be interacting today. From a technical perspective, we can't hear or see you, but we'd love to hear from you and be able to answer any questions you may have. There's a Q&A button on the right-hand side of your screen where you can type your questions at any time and we will get them answered during the webinar. At the end of the webinar, you'll receive an email with a feedback survey. Once you complete that survey, an email will be sent with your CE certificate. So be on the lookout shortly after we get done today for that email so you can make sure and fill it out and get your CE certificate. Now it's my pleasure to introduce tonight's presenter, Dr. Avi Shelemay. Dr. Shelemay maintains a private practice in Ottawa limited to periodontics and implant surgery. Before moving to Ottawa in 2006, he was an assistant professor with the Faculty of Dentistry at the University of Toronto and staff periodontist at Mount Sinai Hospital. He also maintained a private practice limited to periodontics and implant dentistry in Ottawa. Dr. Shelemay is a fellow of the Royal College of Dentists of Canada in periodontology. He obtained his DDS from the University of Toronto in 1996 and subsequently completed a one-year internship at Mount Sinai Hospital. Dr. Shelemay completed his MSc degree in specialty training in periodontology at the University of Toronto in 2002. Dr. Shelemay lectures extensively in the United States and in Canada, the topics of implantology and bone regeneration. It's a pleasure to have you, Dr. Shelemay, and I'll turn it over to you. Thank you.
Thank you very much, Russ, and thank you, Osteogenics and the entire Osteogenics team for organizing this webinar. It is absolutely my pleasure to share with you the next 45 minutes and tell you a little bit about my experience with guided bone regeneration, specifically with vertical augmentation. I think I'm just going to see how I can move the slides forward here. I'm looking for buttons. Here we go. So before I get started, just a little bit about myself. So as Russ mentioned, I'm a periodontist. I practice periodontics in Ottawa, Canada. And my journey started with bone regeneration during my residency. And I was told that bone cannot grow vertically, only horizontally, maybe. And we can definitely do some ridge preservation or socket preservations. What was interesting is that that's when clinicians like Massimo Simeon, Sasha Jovanovic, and Istvan Urban started showing case after case of vertical augmentation. And initially, everyone thought that it's either photoshopped or these are just magicians, and it is not something that can be done predictably by periodontists all around. I kept pursuing this quest for actually learning how to grow bone vertically, and I was able to join Istvan Urban in Hungary over 10 years ago, and that's where I've actually learned all the intricacies, all the little details that enabled me to practice this today on a day-to-day basis with great predictability. So that's a little bit about myself. I'm going to shamelessly plug our Instagram profiles here. On the left side is my Instagram, and on the right side it's Global Dental Mentorship. So I'm part of an educational platform that's online and on demand, as well as in person on educations, particularly in the field of implantology and bone regeneration. You can also see the QR code on the right side, which will take you directly to our Global Dental Mentorship website. So a bit of an outline of what we'll cover today. We'll start with a historical perspective. Where did bone regeneration come from? And then we'll kind of dive into fundamentals of bone defects, which basically means that we need to understand the bone defect in order to determine how to address it or how to regenerate that particular bone defect. And without properly understanding the bone defect, we can't really make the correct choice for membranes, bone grafts, etc. We need to obviously understand how bone heals. because everything we do has to work in conjunction or in synergy with the natural ability of bone to heal. I always tell patients bone has an incredible ability to heal. Unlike skin, that if we cut our skin, it'll form a scar. When bone heals, it heals with tissue that's cannot be differentiated from the native bone. And then we'll dive into management of horizontal and vertical defect. And I'd like to end by managing complications, as well as address some of the more common post-operative things that we can expect to see. And I won't call these necessarily complications, but for someone who's not used to these type of surgeries or who's just starting to perform these type of surgeries, they may seem a little bit alarming. So guided bone regeneration's roots are actually in guided tissue regeneration, which is basically a periodontal procedure. So back in the 80s, when periodontally compromised teeth formed these what we call now vertical bony defects, there were different techniques trying to regenerate bone inside that defect. And one of the technique involved placing a membrane, so cleaning up the defect, cleaning the root, and placing a membrane. So essentially creating a compartment that's completely surrounded by bone. And the idea is that that compartment can only heal with bone because only bone cells can come from the bone surrounding that compartment. Now, in order to regenerate tissue around teeth, it's not enough to just regenerate bone. We also have to regenerate the apparatus that connects the bone to the teeth, which is the periodontal ligament and the cementum. So in a sense, guided bone regeneration is actually a simpler task than guided tissue regeneration, but the principles are the same, which is basically to isolate an area in the bone where the defect is with a membrane, and then we can use bone graft materials in order to facilitate that healing. But the idea is, again, is that if we isolate that defect, then the only tissue that can heal inside that defect would be bone. And this was demonstrated initially by Neyman, where they've actually did a through and through defects in rat's mandible. One site, they basically protected that defect with a PTFE membrane, and the other side was left exposed. The site where the defect was completely blocked off from the surrounding tissue with a membrane, new bone formed. The site that was left open, bone did not form. Now, that was carried forward in another study where they tried to regenerate now bone around teeth. So initially, what Boozer did is place implants in patients, in live patients, and they left a few threads exposed. And the idea, again, was that if they create a compartment around that thread, those threads that is protected by a membrane, then bone would heal. And this is one of the photographs from that experiment. So on the right side, you can see a few threads exposed. And on the left side, you can see that bone grew where the exposed threads were simply by applying a membrane. The next step was to apply it to regenerate in order to regenerate ridges without an implant. So the same thing. The bone was decorticated or perforated in order to encourage bleeding coming from that bone. A membrane was applied, and when the membrane was removed or when the site was reopened, bone formed inside that area. And you can see that in the pictures on the right side. So they were able to demonstrate that the principle of bone regeneration actually works very similar to the principle of guided tissue regeneration. So you have to simply isolate the defect underneath a membrane. And if a blood clot would form inside that defect, and that defect is completely protected from other tissues invading, then bone will form inside that defect. Then they went ahead with a more comprehensive studies, actually utilizing some bone graft in this time, not just a membrane, to help support the membrane. And what's interesting in this study is that They did 66 cases and they broke them down into 3 groups. So the first 22, the second 22, and the last 22, what they found is that the predictability and the amount of bone that they were able to regenerate actually grew. So they were able to regenerate approximately 3 millimeters in the first 22 people. And in the last 22, they were able to regenerate 4.2 millimeters. And that basically taught them that this is a bit of a a technique sensitive procedure. So a little bit of skills, a little bit of experience is required. And that certainly has been my experience. My first few cases were a little bit more challenging. And obviously, the key here is to pick your cases correctly. And as I gained more experience, then it became more predictable, it became quicker. And I started pushing myself in regenerating more vertically and in bigger spans. Now, the question is not only can we regenerate that bone, but the question is this bone actually suitable long term to host an implant? And this was looked at by Boozer, who actually looked at the implants that were placed in regenerated bone and found that there is actually great stability. They basically followed up these patients for 5 years, and they found that there is not that much marginal bone change over those 5 years. And again, more and more people started duplicating these studies, looking at implants in regenerated bone, and they found that the success of implants in regenerated bone was very much similar to the success of implants in native bone. And more recently, Istvan Urban did a few studies where he actually looked at vertical regeneration. So he looked at subgroups, a single missing tooth, multiple missing teeth, and combination of sinus and vertical horizontal augmentation. So that's vertically augmenting the bone, not just inside the sinus in order to gain bone height, but also at the crest level. So getting vertical augmentation from the crest. And what they found is, again, this is just a division. So they found that they've been gaining anywhere from 4 to 7 millimeters of bone. On average, the range was between 3 and 12 millimeters of bone height gain. And when we're looking at the success rate, long-term success rate of the implants, they're able to show that, again, there's no difference between the 3 groups. Implants were as predictable as they would be in native bone. So that's just a little bit of a background on the roots of bone regeneration, and that there's been multiple studies. This was just a small sample of these studies showing that it is predictable, and not just to regenerate the bone, but also for the survival of the implant. So I want to kind of dive now into the armamentarium of the materials that we use for bone regeneration that allows us to regenerate bone. So obviously membranes are involved here. And I'd like to talk a little bit about form stable versus non-form stable. So non-form stables typically are the collagen membranes. So they're soft, they're drapey, and there's no rigidity to them. And they're primarily used for horizontal augmentation. Now, when we're interested in vertical augmentation, we need some rigidity in order to support the defect, to prevent the soft tissue from collapsing into the defect. And that's where the titanium reinforced cytoplast comes into play. So it's essentially a bilayer of PTFE membranes with these titanium struts embedded in the middle of it. And you can bend those struts to form the shape. And essentially, it's a rigid membrane that protects the defect. Here's just, again, an example. So typically the membrane would be stabilized on one side, the graft would be placed, and then the membrane will be bent over the bone graft and tacked and stabilized on the buccal side. So the nice thing again with this membrane is because of these titanium struts, then you're able to achieve graft stability, which is one of the requirements for bone graft to heal. Now, the next thing I want to talk about is about native versus cross-linked collagen. So native collagen essentially has rapid degeneration or degradation. It has excellent tissue integration and early vascularization, which is really important because our bone graft essentially relies on vascularization in order to survive and in order to eventually differentiate into bone. And what some of the studies have shown is that there is no difference in bone gain between short and long resorption time. So one of the things you'll see on a package of a membrane or the insert inside the package is that different membranes will have different resorption time ranging from a few weeks to a few months. The initial thinking, especially when I was in my residency around 2002, was that if the bone takes approximately 9 months to mature or 6 months to mature, then we'd want to have a membrane that lasts that long. Now, this notion, this sentiment has been completely disputed because we understand now that it's actually crucial for the bone to have contact with the periosteum earlier on. So once the bone graft and the clot has stabilized, there is no real purpose. There's no real need for the membrane. So cross-linking of collagen is achieved by UV radiation, chemical or enzymatic. And what essentially it does, it creates these cross-links between the collagen fibers, which increase the resorption time. Reduced tissue, the downside of it is that we have reduced tissue integration and reduced vascularization, as well as reduced biocompatibility, especially with membranes that have been cross-linked chemically, and there could be some residual chemicals such as formaldehyde in the actual membrane. So when I perform any augmentation, horizontal or vertical, so with vertical, I'm obviously using the titanium reinforced cytoplast, but I usually cover that with a second collagen membrane, which is not cross-linked. So it is native collagen membrane. And for horizontal, I'll use only native membrane. Now, I want to talk a little bit about the roots of PTFE membrane. So those of you who are practicing or have been around in the early in the 90s and the early 2000s, they may have heard about the Gore-Tex membrane or the expanded PTFE membrane. So PTFE essentially is Teflon. And initially, that was the membrane that was introduced for guided tissue regeneration in periodontology. The problem was that the membrane was porous because of the expansion. And if that membrane became exposed, then bacteria would actually infiltrate the membrane and the site would get infected. So there's a higher incidence of soft tissue complications. And that led to the development of the dense PTFE membrane, which is completely different. So it is non-porous. It can be left exposed. Not that it's left exposed in vertical augmentation, but in socket preservation procedures, it's a membrane that I use on a daily basis, and I leave it exposed. And when you remove that membrane after approximately 3 weeks, then you'll find that there is this soft tissue that's grown underneath that membrane. So essentially, you're gaining soft tissue. Similar predictability with bone regeneration as the expanded PTFE, but with lower complication rates, fewer infections. The bone graft that's used for vertical augmentation is a mixture of bovine bone and autogenous particulated bone. Now, the advantage is with autogenous bone, that is osteoconductive, osteogenic, and osteoinductive because it has 43 different growth factors. So it's really the only material that can contain these growth factors. Obviously, anything that will come from a donor, you cannot transplant someone else's proteins into a different recipient. The anorganic bovine bone mineral is deproteinized. It is osteoconductive only, so essentially it serves as a scaffolding. And because it has a slower resorption time, it stabilizes the autogenous bone, which is very active and resorbs very quickly. So it is slowly resorbing. And the nice thing is that with a 1-to-1 mixture, you can still gain the same amount of bone as you would gain with 100% autogenous. So the benefit here that we actually don't have to harvest as much autogenous, and we're getting the benefit of the same amount of vertical resorption, and as well as more stable bone graft material. So these are the materials that I use. I use the Xenoprotect membrane. So this is again a native collagen membrane, and this is the Xenogain, which is the bovine bone. This is the second generation of titanium reinforced saddleplast. You can see that the membrane is actually perforated. The original dense PTFE or titanium reinforced PTFE membrane was solid. Now, what these perforations do is allow the bone graft to communicate with the overlying periosteum. So when you remove this membrane, the top layer of the bone graft is actually mature, it's dense. When we used to remove the old membrane, the completely solid membrane, the bone graft underneath it was still granular and it required more time to mature. Usually the implants would be placed and then there'll be another little bone graft performed, and then that graft would essentially mature because it now would have the ability to contact the periosteum of the overlying soft tissue. These membranes have to be fixated. So again, one of the keys for guided bone regeneration is that there is no mobility. And there are different things, different materials that I use to fixate my membrane. So I use two things. I use the Profix tacks, which are essentially these tiny little screws. They're about 3 millimeters long, and you simply screw them through the membrane and into the bone. And there's no pre-drilling that's required. The nice thing is that there is also a screwdriver that would fit over the inside the implant handpiece. So it gives you the ability to screw into the palate or in areas where you don't have direct access for a screwdriver. And the second is these master pins. So these are pins with a little bit thicker pointy part. And the nice thing about these pins, again, that you can tap them into very dense bone and they're not going to bend. And again, even though the kit comes with these little drills that you can pre-drill before tapping them in, I actually never had to use them. There's no problem tapping these pins in. And then when it's time to remove these pins, you simply go underneath them and you just pop them out. And the tacks, the screwable tacks, you simply, again, just unscrew them from the bone in order to release the membrane. Now, for bone grafting, I'll use one of two techniques. I'll either use a bone scrapers. I used to love the Safe Scraper, Russ, which is available from Osteogenics. Unfortunately, you cannot get this in Canada for the past 7 or 8 years. So I found these reusable bone scrapers that you basically just have to replace the blue part. But I'll typically go to a site, usually in the posterior mandible, and you basically run the scraper on the bone, and you'll end up with these shavings of bone that are inside the chamber, and then you simply collect them from there into a dish and mix them with the xenograft. Another way of harvesting bone is with these trephines. So again, you can go in the posterior mandible. Sometimes I'll go into the bone, depending where I'm working. In this particular case, because I was regenerating the upper left, I simply went into the bone on the palatal aspect of the lateral incisor, and I take little cores of bone from there. And then you take these little cores of bone and you place them inside the bone mill. This is a Catin bone mill from Messinger, and you get these bone shavings that again you can then mix up with your xenograft. Now, very important, we need to be able to close everything once we're done. And these are the sutures that I use. So I use the glycolon sutures. I'll use 5-0, and I'll typically reserve the 5-0 for any area in the mucosa. So if I extended my incision posteriorly into the external oblique ridge, then I'll use the 5-0 glycolon, because again, these are slowly resorbing sutures. And the nice thing again is that they're very, very friendly to the surrounding soft tissue. And for the ridge just over the grafting area, I'll use a cytoplast, which is again made from the same material as the membrane, so PTFE. And again, very, very biocompatible. But these sutures have to be removed, and typically I remove them after 3 weeks. So I'm just going to skip now to the next slide, and I can't really skip that, Steve. Sorry, I'm trying to kind of move slides. Oh, I think I moved 2 slides now. There we go. So let's look at some cases. So this patient presented with failed teeth, obviously an endodontic failure, very large cysts. I didn't see him. This is just a preoperative radiograph from another office. He was referred to somewhere else. The teeth were extracted and the site was grafted. I saw him approximately 9 months, I believe, after the graft was placed. And the ridge didn't look great, just visibly. But I proceeded to go ahead with a CBCT to see what the tissue looks like underneath, what the bone looks like. But there is definitely some soft tissue deficiency that I could see, both vertical and horizontal. So this is what we see clinically. This is after the teeth were extracted and after the graft has had some time to heal. And this is the axial slice from the CBCT. So you can see here that there is this radiolucent area in the middle of the graft. You can see that where the graft is. This is very typical of a xenograft. It's very radiopaque, but there's clearly kind of a shadow around it, and there is this dark area in the middle of it, showing that there is definitely hasn't been complete graft remodeling into bone. So again, trying to place some implants using the software, you can see in the cross-sectional image here that there is just not enough bone, and you can see in the axial section that there is quite a significant horizontal bone loss. So essentially, this was fibrous encapsulation of the bone graft. So the way this was managed was with vertical and horizontal guided bone regeneration. So here's a short little video of the procedure. So after raising a flap, and typically the flaps will be fairly large because it's easier to advance large flaps compared to very short, small flaps. After raising the flap, I cleaned up the defect. I harvested bone from the posterior mandible. And now we're taking the titanium mesh, PTFE mesh. And after I trim it, the first tack will always go on the palatal aspect. And the reason is because it's easier for me to place the graft when the membrane is secured on the palate, because I'm looking at the patient from the buccal aspect. Here you can see me using this attachment that goes on the implant handpiece in order to place the Profix tack. So the Profix tack goes right into the bone, and now the membrane is secured on the palatal aspect. And I proceeded to place another tack. Typically, in this type of span, I'll use 2 tacks. And now we can see that I'm taking that mixture of autogenous and xenograft, and I'm grafting obviously inside the defect, and I'm building the bone both horizontally and vertically. And now I'm using the master pin tacks to secure the membrane on the buccal aspect. Now, one thing that's really important with this membrane is that it cannot touch the adjacent teeth. Now, the key to any regeneration, and it doesn't matter if you're using this particular technique or another technique, is to be able to achieve passive closure. And that's where handling the soft tissue and understanding how to release the flap is very, very important. So, because we cannot advance the palatal flap, then the position of the crestal incision becomes very important. The crestal incision is going to be more buccal to create a longer palatal flap. And now, after releasing the periosteum on the buccal, I can achieve a two-layer closure. So I'm starting by placing a horizontal mattress. And the horizontal mattress is going to cause an eversion of the flap margins. So now we have a broader contact between the buccal flap and the palatal flap. And after securing the horizontal mattress, then I'll go ahead and place some interrupted sutures. So again, it's going to be a series of interrupted sutures at the crest, and then I'll switch to the glycolon sutures for the vertical incision. So I'm just going to skip over this, but this is essentially just completing here the horizontal mattress, and you can see that when I tie it, you can see that the flap margins are everted, so there's better contact between the two flaps. So let's look again just at some slides. So here's the defect, the membrane secured with a bone graft. So we grafted both horizontally and vertically, as well as inside. The bone defect, membrane is tacked, and primary closure. This is the healing at 1 week. This is a radiograph just showing the membrane. You can see the titanium strats, how they're protecting the space. And we've gone essentially from the picture on the left to the picture on the right. So now we have more volume of bone, but you can see that there's still some soft tissue volume deficiency. And you can very nicely see that here when we look at the patient's flipper or partial denture relative to the ridge. So there's mucosa that's been advanced coronally. So very often with these type of cases, a secondary soft tissue grafting will be required. So the typical healing time for this procedure is 9 months. So you can see here where we started, and this is after 9 months. So you can see on the axial and you can see on the cross-sectional radiograph that there's been a significant volume of bone added to the defect. And you can see that there is the bone is very homogeneous, and there's no areas of radiolucencies in there. So I proceeded with a stage 1 implant surgery. So again, we have to raise a fairly large flap in order to release the tacks, remove the membrane, and now we have a very significant ridge. I went ahead and placed 2 implants. So these are 2 Nobel parallel CC implants. And again, you can place these implants guided with a pilot guide or old school vacuform guide. It doesn't really matter. One thing that I've noticed is with this technique is the bone quality is incredible. So I would say this is typically a type 1, type 2 bone. You can see a lot of vascularity. The bone is red. So there's a lot of bleeding in the bone. So a lot of vital bone presence in that grafted site. I'm just going to skip here. So the 2 implants were placed. And the next step typically would be soft tissue grafting. So again, can see some volume of soft tissue that's missing. We all know how important it is to utilize a temporary in order to shape the soft tissue around the future crowns of the implant, but you need to have soft tissue. You need to have volume of soft tissue. So what you see here is a partial thickness flap over the crest of the ridge. So there is still a thick layer of connective tissue sitting on top of the ridge. That's why you can't see really the heads of the implants. And now I'm taking another piece of connective tissue graft, and I kind of took a little tuberosity graft here to kind of create a little papilla. And this is placed on top of the ridge. And now I advance the flap again to close over it. So now you can see that there is a straight line going between the two teeth. So we created soft tissue thickness, soft tissue volume. And the next step would be to uncover the ridge. So he created the volume on the buccal here, and then the patient went ahead and got their temporary restorations in order to develop the soft tissues. And that's going to be a process of a few months until the soft tissues are developed before moving on to the final crown. So these are, again, screw retained temporary restorations. And that's him now just with the temporaries. So that's been a very typical patient's journey with a vertical defect. And it wasn't a very significant vertical defect. There was mostly also a defect inside the alveolar housing. Now let's look at another case in the posterior mandible. These seem to be more challenging cases, certainly for me before I've learned this procedure. So this patient presented with multiple failing implants. All these implants were placed, and very short time after they were placed, all the implants failed. Now, she actually had few more implants that were gone by the time I saw the patient. Now, there is a severe vertical bone loss in the posterior mandible, and there is also some significant bone loss in the posterior maxilla. In the posterior maxilla, we have the benefit that obviously we can perform sinus augmentation to gain bone height. We can't really gain bone height in the posterior mandible unless we use vertical bone augmentation. Now, the challenges here is advanced bone loss distal to the last tooth, and which essentially lowers the peak of bone next to the adjacent to the last tooth. And that seems to be always the limit of vertical augmentation, the peak of bone, as well as proximity to the mental foramen. So the ability to adjust or to reflect the flap and advance it. So you can see here that there is a sharp drop in the ridge, and essentially her ridge is at the same level of the floor of the mouth. So there's not much of a ridge there at all. So here is where we started. Proximity of the mental foramen. You can see here, I'm kind of pointing out at the location of the mental foramen. I always tell my assistant where the mental foramen is, so they make sure that they stay away from it with their retractors. And now we have to advance the flap. But for these type of grafts, it's really important to advance both the lingual and the buccal flap. You cannot just advance the buccal flap. And to advance the lingual flap, we really need to understand the anatomy of the floor of the mouth. So we're all familiar with the mylohyoid muscle, which attaches to the mylohyoid ridge. And when we're advancing the lingual flap, I'd like you to think of it as three zones. Zone number one is the tuberosity, it's the retromolar pad area. Zone number two is the molar area, and zone number three is the premolar area. And we have to address all these zones differently in order to advance the flap. So we'll start with zone number one. So for zone number one, what I typically do is I'll simply, when I'm releasing the beginning stages of the surgery, when I'm releasing the flaps, I'll simply go under the retromolar pad and you can see that I'm lifting the retromolar pad, and you'll see that the rest of the flap on the lingual starts actually elevating. For zone number 2, we have to separate 2 layers of the mylohyoid muscle. So the mylohyoid attaches to the ridge, but there is a superficial part of the mylohyoid that doesn't attach to the ridge, is actually attached to the flap. And by separating the attachment of the superficial and the deep mylohyoid, you can actually start elevating the flap in the molar region. So part of the flap will continue elevating with your part of the muscle. The superficial part will continue elevating with your flap, and you can see that flap now is advancing, and part of the muscle remains attached. The deeper part remains attached to the mylohyoid ridge. So you can see that all I'm doing here now is just separating the 2 layers of the muscle. The zone 3 is the premolar area, and the zone 3 essentially is released by simply making an incision, a very, very shallow incision through the periosteum. So there is a short vertical on the lingual flap, typically in the canine region, and a very, very shallow release of the periosteum allows to advance the flap completely from all the way from the back all the way mesially. The next steps is harvesting the bone. So for that, I'm either going to use bone scrapers, or I'm going to take my Trefine and obtain some bone from the external oblique ridge, and then mill that bone or particulate that bone, and then release the buccal flap. When releasing the buccal flap, when we're working so close to the mental foramen, it's really important to simply create a semicircle around the mental foramen. So you want to stay about 5 millimeters or so away from the insertion of the mental nerve into the flap. And it's really important also to make sure that the periosteal release is very shallow. So the periosteum is approximately 75 microns. You want to cut just about 76 microns. So just go a little bit deeper. And then with brushing motions, you can actually start stretching the flap without necessarily damaging the little fibers coming out of the mental foramen and deeper into the flap. Again, damaging these fibers could result in numbness in the lip and chin area. So this is where we started. You can see the vertical bone loss, and you can see, again, the significant bone loss on the adjacent tooth. So the adjacent tooth was sacrificed, and now we have all this vertical augmentation that we gained. And clinically, this is what it looks like. So on the right side, you can see the ridge that has been grafted, and the left side, this is the ridge that we're scheduled to graft in the new year. Again, another example that similar example, but a bit of a different story. This patient had implant failure in the posterior mandible. Again, you can see this significant bone loss. Floor of the mouth is pretty much at the same level of the ridge. And again, the side was grafted. This is after the site is healed. And now we're opening up the site to expose the membrane. So you can see, again, the vertical height. You can see the width of the bone. The pins had to be removed in order to free the membrane. And here is the ridge. And I went ahead and placed 2 implants for a 3-unit bridge in this particular case. So again, the implant were buried, and then the patient came back for a stage 2 procedure to expose the implant and place a connective tissue graft. So here again, you can see exposing the implants. Here are the implants with a connective tissue graft. And that was pretty much the case. So what can we expect with this type of procedure? One thing I tell patients that they're going to develop quite a bit of swelling. And it's really important to make sure that they understand that they're going to swell up and it's going to get worse. Typically, the swelling will peak at about day 3. And I told them that they may even bruise. And I've seen patients bruise from the lower eyelid all the way down the neck. Now, the interesting part is that they look awful, but all they've taken is just Advil and Tylenol. And I've never really received a phone call for anything stronger than an Advil or a Tylenol. So they really look like they hit a bus, but they feel great. They're very swollen. So I encourage them to ice the area in the first 2-3 days, because again, that'll help minimize the swelling. Regardless, they're going to swell, and the swelling will peak at 3 days. Another possible complication is membrane exposure. Now, I've never had a membrane exposure without an infection. So the only time I had a membrane exposure is because the graft got infected. And I'm probably sitting at around 300 or 400 grafts right now. I would probably say about 100 of those are vertical. And I can recall about 2 or 3 infections. So when it happens, it's definitely not fun. There are a few times where I was able to manage it with a second course of antibiotics. So if the patient was on zithromycin, then I'll give them clindamycin, or I'll add Flagyl to the mix. The interesting part that all the infections that occurred in patients that were allergic to penicillin, so they were not treated with amoxicillin, which is my usual protocol. And I spoke to a few colleagues, and they found the same thing, that there might be something in the immune system or the effectiveness of the other antibiotics. And I use either a zithromycin or a clindamycin, not more and more now zithromycin. Apparently not as effective as amoxicillin. So what I do now, when a patient tells me that they're allergic to amoxicillin, I dive in a little bit deeper, because very often they'll tell you they're allergic to amoxicillin, but it could have been a rash that they developed when they were a baby that could be completely unrelated to the antibiotics that they were actually given. So when infection occurs, the best thing to do is just open up the flap and remove all the infected graft material. Now, sometime in this particular case, the entire graft material was infected, so the whole thing had to be removed, irrigated, and then just get primary closure over the area and let the soft tissue heal, and then you can go back again. If the infection is very focal, so it's very small area, so once you remove that focus of infection, the rest of the graft looks nice and red and it bleeds, then you can leave that alone. Simply cover it with a collagen membrane, close the flap over. Don't try and get primary closure. And what's nice about this technique is even in areas that got infected, then you'll still be able to get enough bone to place the implant, but you may require additional bone grafting at the time of implant placement. So this pretty much concludes my presentation for vertical augmentation, and I showed you kind of anterior maxilla, posterior mandible. We do a lot of single site teeth where the buccal and palatal wall are missing. And the key takeaways from this is that vertical augmentation is possible. It just requires us to really understand the details. We really need to understand how bone heals, how bone grafting works, what type of bone grafts do what, and also technically, it is a little bit more finicky. So it's just a matter of taking the right courses, speaking to the right people, understanding the little nuances of how to secure the membrane, how to release a flap, and so on, and get primary closure. And again, this is daily practice in my office. And I'm very happy to offer this to my patients. And these are a lot of patients that have been trying to get implants in other places and were told that they cannot get implants. So it's really, really rewarding to be able to provide them with this type of solution. So I think I'm pretty much done here, Russ. I don't know if we have any questions. I'm happy to address those.
Great. Yes, we do have several questions that have rolled in. Appreciate the presentation. Great information. And think it was extremely beneficial. So let's start with the first couple questions. First one: how much vertical height can you expect um, if you're I guess what are your limitations or what are your expectations on maximum amount of height or a predictable amount of height that you can get with this protocol?
So I've been able to get, say, up to 10, 11. So that's the more extreme cases, like the posterior mandible that I've shown you. We have to also understand how much vertical heights do we need, right? I mean, so if we can place a 10 millimeter implants or an 8 millimeter implants, we don't necessarily need to regenerate 20 millimeter bone height. But the most I've been able to regenerate was about 10, 11 millimeters bone height vertically. I know that some of the developers of this technique were able to regenerate 15, 16, 17 in severe cases of not just tooth loss, but complete trauma to the alveolus and to the maxilla, where they had to regenerate obviously the bone where the implants are going to go, but also the bone apically to it because of trauma.
Understood. How long should one wait before placing an implant in the maxilla and or the mandible after doing one of these vertical ridge augmentations?
Yeah, that's a great question. So I wait 9 months. Now, in smaller site, edentulous sites, so let's say, and a lateral incisor, let's say, that lost an implant failed and lost the buccal and palatal bone. So smaller sites, I'll wait maybe 7 months, and it should be fine. But for the larger cases, I'll wait 9 months, the full 9 months, not less.
And you're, I guess, to be clear, most of the time, are you placing your implants at time of membrane removal?
Correct. Yeah. So
Okay.
at the time of for vertical augmentation, like I said, typically for large sites, 9 months, and that's when we raise a fairly large flap, simply so I can get access to the tacks. On a side note, for horizontal grafting, I'll wait about 6 months, and I will not necessarily make a big flap, because very often, if a tack is not in my way or in the way of the implant, I'll just leave it there. The membrane will be gone by then. You can't do that with the PTFA membrane, because you have to obviously remove the membrane. It's a non-resorbable membrane, so you have to remove all the tacks. But with collagen, you can leave some of these tacks in there indefinitely. There's no real reason to raise a big flap and go after those tacks.
Understood. It's a good question. We get this a lot. How long do you wait before doing a soft tissue graft? And so I think that's the question. But there's also talk about, do you do a soft tissue graft post ridge augmentation? Do you do it at the same time you're doing a ridge augmentation? Do you do it before you do a ridge augmentation?
So I never do it before I do rejuvenation. I try to minimize the scar. One of the things that I really want to do with a time of ridge augmentation is to advance the flap. So the more challenging cases for ridge augmentation are not necessarily cases where you have a lot of vertical bone height that you need to regenerate. The more challenging cases are cases that had multiple surgeries, and now the periosteum is so thick and so scarred, So in order to release the periosteum and to advance the flap, you almost have to cut the entire periosteum off. So I try to minimize the amount of surgeries I do before ridge augmentation. So I'll do all the soft tissues typically after ridge augmentation. So typically the sequence for me would be ridge augmentation, implant placement after 9 months, and then usually I'll wait 6 weeks after implant placement. So typically I wait 3 months for osseointegration, but 6 weeks, the halfway point of those implants integrating, I'll go in and augment the soft tissue. So then when the implant's fully integrated, 6 weeks after that, I can simply go ahead and now expose the implants. So I have the soft tissue volume to work with.
Gotcha. Excuse my pronunciation here, but got a question about antibiotics. Have you tried cephorexime Exetil for penicillin allergic patients?
No, I have not, but and that's I'll look into that. If that's is that I'm assuming is that one of the if that's one of the cephalosporins, then can certainly look into that. As I know that there is about 10% cross antigenicity between cephs and penicillin, but that's definitely something to look at. But I find it's very interesting that people who had complications, higher rate of infections, always allergic to penicillin. And in my case, it's been 100%.
What you're thinking about ridge splitting to expose the medullary bone and provide better access for regenerative cells?
So ridge splitting, I used to do a lot of ridge splitting. The problems that I had with ridge splitting is that when you have very thin bone and you split it, you end up with even thinner bone, typically on the buccal. And that bone will be particularly thin close to the crest. And it typically would die back because it doesn't have any medullary bone on in that split, in that little bone flap that you created. And as a result, if you didn't want to have your implant exposed, you had to sink the implant deeper because you're going to get some dieback of that little bone. So I found it much more predictable in my hands to regenerate the ridge and place the implant. Now, sometimes I'll do a simultaneous implant placement and grafting if I have few threads exposed on the buccal. But if the ridge is very thin, then I'd rather graft and place the implant as opposed to split. That's been my experience with ridge splitting.
Okay, great. Just a couple more and we'll wrap up. But we get this. It's a great topic and good to get your perspective on it. But custom titanium meshes are something that are a hot topic right now, and you hear various pros and cons with them. But what's your experience with any, if any, with custom made titanium meshes, and how would you decide between using a titanium reinforced PTFE product versus a custom mesh?
It's definitely a great question. I think I'm definitely kind of interested to learn more. It's a newer technology. The advantage of the costume titanium mesh is that it's less finicky. One of the most finicky parts of these procedures is adapting the membrane, securing the membrane, tapping the membrane with a tax. With a custom titanium mesh, basically you just put the bone in it, and it kind of looks like a taco shell, and you just basically flip over the ridge, and it fits exactly the defect, and then you just need a couple of screws to just secure it in place. Historically, the issue with titanium mesh was early exposure of the mesh, fairly high rate of mesh exposure. So what I don't know yet is, did this technology solve that problem, or it just provided essentially a titanium mesh that's already pre-custom fit to the ridge, so you don't have to spend time trimming a titanium mesh and fixating it the same way you would a membrane. And so I'm not sure I'm not sure where the what the verdict is at this point. So it's certainly something to keep an eye on. And I know that there's different design of mesh, different designs of the porosities. Um, Again, are these all intended to try and minimize exposure? Which one worked better than the other? I think the jury is still out on that.
Okay, and we'll wrap it up with this because this will answer at least three questions that have come in. Can you just speak to the provisionalization of these patients when they're leaving the office? And is there a different, what can these cases, what should you avoid when you're talking about provisionals? What are acceptable? Is there a difference in how you provisionalize a posterior case versus an anterior case? Just provisionalization in general.
There's a great question. Actually, it's kind of interesting. I have a quick a case now that'll help answer that question. So I'll quickly go over this. This patient presented with a failed lateral incisor. You can see from the cross-sectional CT here that there's absolutely no bone on the buccal or the lingual. So this is not a case for an immediate. Here is the tooth was extracted. I gave a few weeks for soft tissue healing, and you can see the defect here. So again, grafted it with a titanium reinforced cytoplast mesh, closed everything, let things heal. You can see now the ridge post-grafting compared to the ridge pre-grafting. Removing the membrane, removing the mesh. I'm just going to skip through the video here. So here's the bone. This is where we ended compared to where we started. Placement of an implant through a pilot guide. And after the implant is being placed here, this is a Nobel parallel CC implant. I'm going to run through these slides again. So this is where we started. There's a bit of a delay with the buttons here, so I'm just going to click on the next. And in this particular case, I actually temporized the implant right at the time of implant placement. So she had enough soft tissue there. Again, because the tooth was there, because this is not a ridge that was allowed to completely collapse. The soft tissue was there, so I didn't need to do any soft tissue grafting. So absolutely, when I place the implants into these sites, I use the same consideration as I would as if it was a native bone. So if I get good torque of the implant, and typically I'm looking for 35 Newton centimeters. If I get that, then I'll have a provisional. I'll temporize it and use that to help sculpt the soft tissue. So once we have the other key thing is, I think with these type of cases is that your choice of implants. So I really like the ultra surface with the anodized top portion, which allow for a little bit better soft tissue attachment. It's less, there's no porosity in it. So it's a little bit friendlier in case of exposure. So just being a little bit more careful. But other than that, I treat it the way I treat any native ridge.
Thanks, Dr. Shelemay. And we did not set that up to where I asked a question. He had a case queued up to answer it. It just happened, which is awesome. So we appreciate your time tonight, and thanks everybody for logging in. Last thing I'd just say is keep an eye out for the email that you'll be getting shortly with the questionnaire about the webinar. Once you fill out that questionnaire and submit it, that will initiate us sending you your CE certificate. So I hope everybody has a good Wednesday evening, and look forward to the next webinar. Thank you, Dr. Shelemay, again.
Thank you, Russ. Thank you, Steve. Thank you, Osteogenics, for organizing this.